my honor and pleasure to introduce Lucia De Franceschi. Lucia is professor of internal medicine at the University of Milan. She was trained in Boston in her young life, and under the supervision of Carlo Brugnara, and she became very interested on red cells. She is practicing in a northern Italian region where sickle was not common, but due to previous migration, not only the recent one, there are huge community of sickle cell patients. So she set up a clinic and she has a lot of experience and she's involved in many clinical trials. Yeah.
Thank you, Nika, and thanks to IA for giving us the opportunity to bring sickle cell disease to your attention. I have nothing to disclose, and the title they give me is really complicated in 10 minutes, so I try to drive you through these 10 minutes running towards treatment, and the contribution of the speaker before me helped me in define the two main clinical presentation of sickle cell disease that require intense treatment, which are chronic hemolytic anemia and acute vaso-occlusive crisis, for which still unmet therapeutic needs are present, in particularly in identification of acute events, prevention, and treatment of them. So if we look at the leading causes for admission of patients with sickle cell disease to emergency department, which is summarized in this slide, you see that the acute pain crisis, acute chest syndrome, acute abdominal pain, pneumonia, and septicemia are the main causes. And if we look to the natural history of vaso-occlusive crisis using the well-defined profile of development of acute pain crisis in sickle cell disease made by Ballatz and co-workers, you see that there are four main moment, and we are called to do and to identify this vaso-occlusive crisis early in the early phase to make the difference for the patient. Acute pain crises are a terrible, devastating experience for patients since they are in their pediatric life. So the importance to interference with the development of more severe and complex complications such as the acute chest syndrome is very important. In the panel on the left is just a graphic representation of what is the acute pain crisis for the patient. So there is a continuous acute pain with breakthrough pain episodes which really make the life of this patient terrible. So with groups of different groups worldwide, try to understand how to deal with sickle cell disease patients arriving to the emergency department. What is evident from different studies is that sickle cell patients are the large utilizer of emergency department compared to severe patients with severe hemoglobinopathies, such as beta thalassemia patients. And what is coming out is that sickle cell patients experience longer waiting time at the emergency department for pain treatment compared to other populations with similar pain intensity, such as patients with pain related to renal colic. And the management of acute pain crisis improves emergency department physicians, but also nurses that generally do the triage of these patients receive education and guidelines and variables. What it comes out is that truly exist barriers throughout the different nations and countries, and also different health systems where there are patients with sickle cell disease, showing that there are social cultural factors that can affect pain management for this patient in emergency department, also such as also concerns by physicians from the emergency department in using opioid-like molecules for possible addiction or pseudo-addiction in these patients. So, for example, in Italy, we tried to develop an algorithm to help physicians for emergency department to deal with patients with sickle cell disease when do arrive at the emergency department for acute pain crisis. And as you see in this slide, you have management for adult patients, for children, and with different coded triage in order to give them the optimal treatment for pain. And in this flowchart, we also developed a pharmacological flowchart in order to obtain the better control for pain. As you see, you can follow the treatment, and you see that there is a continuous titration of the treatment based on the pain evaluation with the patient, and the use of a balanced analgesics, which means to use different molecules, such as, for example, ketorolac or tramadol, which is an opioid-like, or morphine if tramadol fail. But what is very interesting is the use of pain-breaking drug, such as the rapid onset fentanyl formulation, which are only recently available in the emergency department. And as you see in the lower part of this slide, there is an improvement in pain perception by the patient, in amelioration of the saturation of the oxygen in peripheral oxygen saturation in this patient. But what is very important is a satisfaction of the patient after the pain crisis. Why is it important to treat the pain crisis and to identify correctly the pain crisis? This is important for a patient, for their life, but also because patients that receive and not focused treatment in the emergency department, they come back to the hospital. And in this study, where they evaluate the rehospitalization of sickle cell patients at 14 and 30 days after the hospitalization, what it come out is that patients with sickle cell disease generally come back after 30 days after the hospitalization, and generally for pneumonia, asthma, or heart failure. And within the adult and pediatric population, those ones that are coming back are those around the 18 and 30 years of age, probably related to the worsening of the disease, but also related to difficulties in transition between the pediatric care and the adult care. So which are the available treatment that we can count on right now? I try to summarize this in this slide. As you see, you have the hydroxyurea dominating, then you have different transfusion regimen, you have the stem cell transplantation, and actually coming out also gene therapy. But you see, you have still factors that are only partially controlled by these treatments, such as the red cell dehydration, the chronic hemolysis, and the inflammatory vasculopathy. Hydroxyurea is a fantastic molecule. It has a multimodal action, is able to interfere with the chronic hemolysis, acting on the synthesis of a fetal hemoglobin, reducing the chronic hemolysis, interfering with neutrophil activation, interfering with the abnormal activation of the endothelium, and also increasing the NO synthesis, beneficially affecting the imbalance in the vascular tone. So the introduction of hydroxyurea has definitely changed the scenario for the treatment of patients, both children and adults with sickle cell disease. But the major obstacle in the use of hydroxyurea in patients with sickle cell disease is the adherence of sickle cell patients to the treatment. And this is related to multiple factors, such as the fact that these patients are under chronic medication, there are social economical reasons, and again, we have the transition problems between the adolescents and the adult care. Several strategies are under evaluation to try to find some trick to improve the adherence of sickle cell patients to hydroxyurea. So we still need molecules to interfere with the pathophysiology of the triggering event involving the pathophysiology of the vaso-occlusive crisis in sickle cell disease, and these are being designed according to identification of factors extrinsic to red cells involving neutrophils, vascular endothelial cells, or intrinsic to red cells, such as the sickle cell hemoglobin polymerization. How we can interfere with factors extrinsic to red cells. So recently, what it came out, and David Rees also mentioned, is the novel role of selectin, which are proteins that are released by endothelial cells and participate to leukocyte adhesion and the generation of heterothrombosis between red cells and leukocytes. What is interesting is that we can block selectin through different strategies. One is a pan-selectin antibody antagonist, and the other one is a p-selectin antibody known under the name of crenalizumab. So we have recent studies coming out and presented at this meeting, presented here in this meeting last year and this year, and then published on the New England Journal of Medicine, showing that these antibodies are able to affect the pain crisis, to increase the delay time between one pain crisis to the other, especially at the dosage of 5 milligrams per kilo in patients with sickle cell disease. And the sustained study have shown that patients with sickle cell disease with different genotype have beneficial effect with crenalizumab, the dosage of 5 milligrams per kilo with the administration of 5 every 4 weeks, and this was effective in increasing the length in between pain crises, was also well working with patients with hydroxyurea, but no synergistic effect was observed between the two molecules, but this later observation has some limitation due to the short number, so a small number of patients that were under both treatment in this study. And if we want to interfere with the intrinsic factor related to red cells, so there is a new molecule, a very interesting molecule, which is a small molecule, is an oral available potent antioxidant, anti-sickling system agent, which is binding to sickle red cells, is shown in this 3D reconstruction of the hemoglobin, is able to block the mobilization in part of hemoglobin S, and is being demonstrated to be effective in mouse model and in vitro. But we have data also in patients showing that this compound is able to, first of all, is well tolerated by the patient, is able to reduce the red cell hemolysis and reticulocyte count, to decrease EPO, that means to increase the expansion of the erythropoiesis. And the data on phase 2 study showed that there is an improvement in the hemoglobin levels and a sustained reduction in the reticulocyte count. So I hope to convince you that to treat sickle cell disease means to multi-target different phenomena that are involved in the pathogenesis of severe complications such as vaso-occlusive crisis in sickle cell patients. This means probably in perspective to consider possible combination of hydroxyurea with the new molecule or without hydroxyurea between the different molecules. And I think that the conclusion can be that novel treatments are required, and they should be designed based on the pathophysiology of sickle cell disease. But we have also to remember that an holistic approach is required, and we have to also to consider the patient quality of life when we design new clinical studies. And I would like to thank patients, their families, physicians that are devoted to sickle cell disease, to care of sickle cell patients, to do research on sickle cell patients, and to sickle cell patients that are arriving to the European coast right now from endemic area for sickle cell disease. And I thank you.
Thank you very much. So that sort of concludes the speaker part of our afternoon. Another third sort of summary presentation there, which I hope has been useful for you in terms of information. So now we're going to move on to the discussion part, and it's really important that you feel that you can take part in this. So do come up to the microphones if you have any questions. Don't be shy. There's one at the end of each of the aisles. Yeah. I'm going to kick off just with a statement to get the discussion going via the panel. So I'm going to just start, just kick things off. Actually, sir, would you like to ask a question first, seeing as you're there?
Yeah, thank you. Salam al-Kindi from Oman. First of all, we would like to thank the IHA for highlighting the burden of sickle cell disease worldwide. I have few comments. First, about the neonatal screening. I think we need to be a little bit careful with the beta thalassemia trait, because some of these cases may be missed at the time unless you have a very good, clear idea of what's your level of hemoglobin A that should be adopted at time of birth. And that means it requires a repeat at 6 months. And beta thal trait is very important, not to be missed in these cases. The second is there are people who will debate if you have an S, if you have a band running in the S, is that only S or could it be another variant? So we have to have another method of confirmation, but that could be debated. Like, for example, a sickling test to confirm that actually is an S that is migrating in that column. I agree with Professor Rees that an SC is quite mild, and our problems with it is of threefolds. Its impact on the eyes, which I agree with. Also, its impact on pregnancy morbidity. And the third is the skeletal manifestations. Apart from this, I think for us, SC is a fairly mild disease. And I also want to highlight that the use of the term pneumonia is not really, for us, I stop people from using the term pneumonia in sickle and rather use acute chest in all the time, because if you use pneumonia, people can be sent home on oral antibiotics and they can deteriorate. And actually acute chest syndrome does not say anything about the etiology. It's a syndrome. So it could be an infection, which could be a pneumonia. But so the term pneumonia, I think, should be avoided if possible. And I think when the term acute chest has been coined, people have actually moved away from the use of the term.
Okay, I'm just going to, just because I'm aware of time, any comments from the panel on that?
Maybe David.
David,
David, you can comment on this last point.
In response.
No, not really. It's fine. I think the thing about SC is interesting, really, that it's clear that there's not much evidence on how to manage SC, and there's a diversity of opinion, clearly. We certainly, the thing about venesetting SC, I think that may or may not be right, but there's no evidence to support it, and it may be that we need trials to look at things like that, but as it stands, that's certainly not standard management, certainly not in the UK. I mean, I think there were complications and issues, and I think it's something to think about. But I wouldn't want people to go away thinking that this is how you manage SC patients in general.
Okay.
So if I can just comment the point on pneumonia, I think it's important for physicians who are not aware or they don't know the disease, and the risk actually is to say, okay, you have a pneumonia, get the antibiotic, go home. Actually, these patients who, let's say, respiratory problem require better attention, because they can start maybe with pneumonia and develop acute chest syndrome. But that doesn't mean that we have to remove the definition of pneumonia. We have just to be aware that these patients require a better attention to the respiratory problem.
I mean, talking about sickle cell from a completely different part of the world also would add to what we're...
Yeah.
I mean, this is a completely different perspective, different area, so it will probably help in learning from each other.
Okay, so I can see two other gentlemen standing up. Sir, I think you were first.
Miguel Aboud from Beirut, and I would like to thank IHA again, for bringing this forum on. And just a couple of comments on the hemoglobin SC disease. I agree with David Rees that that's not a standard of therapy. We still don't know what to do for these patients, but all the studies that are there suggest for the patients with SC disease who have severe manifestations, and they're granted as a percentage, they're fewer than SS, but they are there, that hydroxyurea is most likely beneficial. In fact, there are 3 or 4 publications, including a large publication in the American Journal of Hematology, to that effect. So I would not withhold hydroxyurea from these patients. Yes, one would carefully look at their hemoglobins, but usually their hemoglobins don't go up on hydroxyurea. So I would not withhold hydroxyurea from those patients. And again, excellent presentation on new agents. However, I cannot stress more the need to utilize hydroxyurea to its maximum impact. And I find, talking to some colleagues in parts of the world where sickle cell disease is prevalent or not so prevalent, that there are 2 extremes. Either people are terribly afraid of hydroxyurea, or are very gung-ho and they give hydroxyurea, as my friend Russell Ware would want, to everybody at maximum doses. And I think that one should carefully weigh there, but hydroxyurea definitely needs to be used much more than it currently is. Thank you.
Yeah, may I comment?
Yes, of course.
I think that the 2 points that Miguel offered to us is very important. The first one is the SC. We don't have to forget that renal complications are always close to a SC patient, and I think that since the population, especially in our context, Europe, as well as in the United States, is becoming older, we are going to see more complications, especially in patients that up to now are really, not so deeply affected by the disease. And the second point on sickle cell disease, on hydroxyurea, I think that it's very important that each one of the physicians give the opportunity to the patient to have the compound. And then when I mention education, I think that the alliance between patient and doctor and physician in order to identify the objective of the treatment, so to use hydroxyurea, is very important. On the other side, we need new tools in order to empower our ability to control and to treat the disease.
Okay. Yes, of course. Yes, gentleman on the right there.
How do you pick which patients are appropriate for stem cell transplant, and will new drug approvals change that?
Who would like to take that?
Stem
Dave,
cell
what was the question?
transplant.
Could you repeat the question about stem cell? How do you select
Stem cell
patients for stem
transplant.
cell?
Patients.
Well, I think it's a difficult area, really, and the opinions range from saying that everyone with a sibling donor should have bone marrow transplant to only transplanting those people with sibling donors who have the severe complications. Our practice is mostly if someone is basically transfusion dependent for one reason or another, mostly for cerebrovascular disease, but for some other reason, then we would consider bone marrow transplantation if they have an HLA identical sibling. I'm not a transplanter. I'm not a particular advocate of transplantation. The more difficult issue of alternative donors using haploidentical or unrelated donors is more difficult. The outcome is certainly much worse than in sibling donors, and although there may be a place for them for people who have relentless progressive disease despite optimal treatment, I think the current role for those is quite limited and should be really confined to proper controlled clinical trials. I think it's important not to equate HLA-matched sibling donors, for which there's a lot of good evidence that there's an effective treatment with good outcomes, with new alternative donor transplantations, which are experimental with at the moment with poor outcomes.
Any further comments on that from the panel at all?
So are you transplanting all of your patients with sickle cell disease that have HLA identical donor and are transfusion dependent?
Sorry?
Are you transplanting your patients now?
Well, if they have an
Those that
HLA sibling donor and we've taken the decision that they're going to need long-term transfusion, then we would offer them transplantation, yeah.
They're accepting the patient?
Yeah, most do, but mostly parents are very keen. I have a pediatric practice. Parents are very keen on curative treatments and probably more keen than I am.
Interesting. Thank you very much. We're doing very well from the floor, by the way, so there's another question here.
Hello, I'm Francesco Cirisoli from the EHA office. And yes, you have announced that this is a program. It's not just a session, it's a program of EHA. So to this very nice panel, I would like to ask, what is, in your opinion, the most urgent action that EHA can undertake for SCD?
So if I may start, and it's just some ideas, I think that there are two levels. One, I think, is dissemination of the knowledge, especially in real life. That means emergency department of internal medicine, hematologist, and a pediatrician. So we have to know about sickle cell disease, how to deal with acute events, because patients, experience acute events constantly during their life. And then the second one is to give visibility to sickle cell disease. Patient, and it's very interesting if you compare the ability of sickle cell patient to associate and to make the disease to come out. This is very difficult for them, more difficult than for other hematological diseases. So I leave the audience to think about the reason. But I think the society, a scientific society, should also be the vehicle for them to become visible to the society, to political point of view, to support their action, to support research. We don't have money to do research, or a small amount of money compared to lymphoma or leukemia. I'm not saying that this is not a problem, but I'm saying that we need attention. So we need money to do research to improve, I think, our tools.
Yeah, I want really to underline that, because among the audience, I'm sure there are experts. Usually the attendees are the experts of the subjects. We need to reach the non-expert, because sooner or later they will be facing the problem of sickle cell patients because of population movement, because even in our own country or in country where sickle cell is present, Northern Italy was not expert like South, but now students and so move. So that is an important issue, to touch not the expert, but the non-expert. And as Lucia said, the European society must have, first of all, this mission. All the rest come as a consequence. Improving treatment and so on.
Also, I do believe that your interest as IHA should go way beyond Europe in this. So sickle cell have been there since ages, not only now. I understand that now with the influx to Europe and these differences in Europe, but it is a common disease worldwide. 8% of the population are carrier, and I think whatever Lucia is talking about, education or clinical trials or new therapeutic areas, should go way beyond. It is a global disease.
Yeah, I agree entirely with Ali that one of the glaring thing with sickle cell disease is that nearly all the patients live in southern hemisphere low-income countries, and EHA needs to help build the north-south collaborations. There are some very good examples of that have been talked about here, but that is the really big problem. We have problems in Europe with it, certainly we need to do better, but that's minuscule compared with the other problems in the world.
Yeah. And how do you think that can work, sort of reducing that north-south divide?
I don't know, EHA gave lots of money for us to do research in African countries with African investigators.
May I?
Yes, of course, yes. Definitely.
Well, sure. Until recently, the internal medicals were not affected with sickle cell disease. These were the pediatricians which were in charge. So, and there's a good study that changing from pediatricians to internal medicine increases the death rate. So I think it's very important to recruit doctors from the internal field which will be in charge of sickle cell disease, which are not apparent right now in Germany.
Rapid question. Do we need guidelines?
Sorry?
Do we need guidelines on SCD in Europe?
Do we need guidelines?
Yeah,
yes, or quick yes
so
or
we
no?
have European guidelines. Each country has developed its guidelines. And we were discussing a small group of experts. I think we need to work together in order to offer the same standard of care.
And to implement. The guidelines, because guidelines,
to more available and to implement.
Thank you very much. Okay, so we've got probably the final question now, because we've got 2 minutes left.
Baba from London, obviously with interest in Nigeria and Africa. There is the EuroBloodNet, which is an ERN of the European Union, and we're really very keen to try and harmonize newborn screening and also registries across Europe. So there is an urgent need, and a European EHA EHA can really be a very good partner and working with us in the EuroBloodNet to try and enhance registries. Registries in England is UK, they have one, and we're trying to see how we can harmonize that across. But actually, I cannot overemphasize the impact for a North-South collaboration to strengthen the management of sickle cell disease. And just finally, you presented a very good abstract yesterday about the diagnosis of migration. These people, when they arrive, we could screen them at the port of entry. Because, when you think of migrants, you think about migrants trying to go for economy, but actually when you think that there are sickle cell patients there, actually it's good that we could do something about it.
Yeah, thank you.
Okay, one very last question, very quickly.
No, I just have a quick comment about guidelines. You know, there were guidelines that came out from the NIH a few years back. Now there's new guidelines coming out of EHA, of ASH, and there's a group of us who met together to put more guidelines. The problem is not guidelines. I know they drive up the impact factor of the journals that publish them, and that's a big driving force. Yeah. But the problem is there is no data. In sickle cell disease, we have very clear data for a few things, and they are not being done. And in the other areas, there's no data, and I'd love to sit and discuss, and we can argue forever and come up with a set of consensus agreements. But what we need is data, and we need societies like EHA to fund studies that will give us the data that will allow us to get good evidence-based guidelines.
Yeah.
Lovely, thank you so much for that, and a really interesting discussion. We could stay here all night, I feel. Lots of topics coming up there, registries, migration, guidelines. I'd just like to thank you all for attending. Thank you for your questions. That's been a brilliant session because we heard from you, which I think is really important. I just want to thank both the chairs and the three speakers, and please keep an eye out for further parts of the programme for this particular topic in focus. Thank you very much for joining us.